Hi everybody. Today we are going to learn about COPD. What is COPD? C stands for chronic, O obstructive, P pulmonary and D disease. Chronic obstructive pulmonary disease. What is chronic obstructive pulmonary disease? In COPD causes obstruction to the airflow from the lungs. That means airflow is limited. There are two conditions that contributes to COPD. That is chronic bronchitis and emphysema. What happens in chronic bronchitis? The bronchi is inflamed and there is excess mucus production. It limits the airflow. What happens in emphysema? In emphysema, the alveoli sacs are damaged, which impairs the gas exchange. So chronic bronchitis and emphysema may lead to COPD. Now let's look into the anatomy of the respiratory system. Air enters the nose, moves into nasal cavity, throat, which is also called oropharynx, then into larynx, which is voice box, enters the trachea. Trachea divides into bronchi at the point called carina. The bronchi enters each lung at the point called hilum. The bronchi further divides into secondary, tertiary bronchi, finally into bronchioles, and the bronchioles ends up in alveoli sac, which has alveoli. The alveoli sac, the alveoli is covered with capillary networks, a blood network, and it helps in gas exchange. So what happened? Now let's see the pathophysiology of COPD. In chronic bronchitis, this is the healthy bronchi, whereas in bronchitis, you can see the bronchus is inflamed and there is excess mucus production. So the airflow is limited. When the airflow is limited, it decreases the oxygen in the blood, called hypoxemia. So when hypoxemia happens, body tries to compensate it. What is compensate? Whenever something bad happens to the body tries to fix it. So body tries to produce more RBCs for oxygenation of the tissues. It won't help. Instead, it makes the blood thick. When the blood gets thick, remember the pressure in the pulmonary artery increases. The pulmonary artery carries deoxygenated blood to the alveoli. So when the pressure increases, called pulmonary hypertension, there is a backflow of the pressure back to the heart, causing right side heart failure because the pulmonary artery originates from the right side of the heart, leading to right side heart failure. What happens in emphysema? In emphysema, look at the healthy alveoli, it's nice and round. But in emphysema, the alveoli is damaged. It cannot inflate and deflate with respiration. Remember, alveoli inflates when we breathe in. So when we breathe in, it inflates and air moves into the alveoli. It helps in gas exchange. That means the carbon dioxide moves out from the blood vessels to the alveoli and oxygen moves into the blood, oxygenate the blood. And when we breathe out, this alveoli deflates and helps in the exhalation of the carbon dioxide. So when the alveoli is damaged in emphysema, this gas exchange may not take place. The alveoli cannot inflate and deflate. The carbon dioxide cannot fully exhale from the alveoli and air get trapped in the alveoli. So air get trapped in the alveoli sac. That leads to hyperinflation of the lung. If you look at the X-ray, this is the normal lung, whereas and this happens over time. The lung is enlarged, hyperinflation of the lung. So when the lungs get hyperinflated, it affects the diaphragm. Remember the diaphragm at the bottom, and normally the diaphragm is dome-shaped. The diaphragm is a muscle that plays an important role in respiration. When we breathe in, the dome-shaped diaphragm flattens. It increases the thoracic cavity, creating a negative pressure, and air moves in, so we can breathe in easily. But in hyperinflated lungs, the diaphragm is affected. It cannot help with the respiration, so the patient start using the accessory muscles, that is neck and shoulder muscles, And also there is increase in the anterior posterior diameter of the chest because of the hyperinflation of the lung. This is the normal. Whereas in chronic COPD, there is increase in the anterior and posterior diameter of the chest called barrel chest. So in emphysema, you will see patients started using the accessory muscle and barrel chest appearance. Now let's see what are the causes of COPD. COPD is mainly caused by inhalation of harmful irritants. One of the major cause is smoking. But it is also seen in non-smokers, people who are living in area where there is high air pollution, and the chronic exposure to this can also lead to COPD. Also, people who inhale harmful fuels or in workplace exposure or inhalation of harmful chemicals can also lead to COPD. Also, there is a genetic cause, deficiency of alpha-1 antitrypsin. This is a protein produced by the liver and it protects the lungs from the inflammation caused by the harmful irritants or from infection. So when there is a deficiency of alpha-1 antitrypsin, it can also cause COPD. Now let's see the signs and symptoms of COPD. Remember, the signs or symptoms vary from mild to severe. This is irreversible. What is irreversible means? It's not curable, but it is treatable with lifestyle modification and medication. The symptoms may worsen over time. The patient has chronic bronchitis and emphysema, so patient may experience wheezing or abnormal breath sounds like diminish or hoarse crackles. Patient may feel difficulty in breathing, shortness of breath, dyspnea, chest tightness, cough. Usually may be productive as is seen in chronic bronchitis or may be dry. Along with its cyanosis of the lips, mucous membrane, nail bed, barrel chest, tripod position, that is, patient lean forward to breathe. Weight loss due to inadequate nutrition, swelling, this is all secondary to the complication of COPD, swelling of the feet, ankle, leg, secondary to right side heart failure, frequent respiratory infection, and in ABG, you will see hypoxia, high carbon dioxide, and when there is high carbon dioxide, hypercapnia, pH decreases, that is respiratory acidosis. So what are the complications of COPD? Patient with COPD can have spontaneous pneumothorax. Why? Because remember, in emphysema there is air trapped in the alveoli. Alveoli cannot exhale the air. So the structure of the air can lead to air blister, can lead to pneumothorax, repeated infections, hypoxia that leads to polycythemia, and I explained this in pathophysiology, increased RBC count, multiple exacerbation, hospitalization, leading to end-stage lung disease. There is right side heart failure, also increases the risk for lung cancer. How is COPD diagnosed? Lung function test. In lung function test, example spirometry, it measures the amount of air inhaled and exhaled. ABG. In ABG, you will see hypoxia, hypercapnia, increased carbon dioxide. Also, the pH drops. So, it leads to respiratory acidosis. 6-minute walk test. It measures the distance an individual able to walk over a total of 6 minutes. The purpose of this test is to measure the exercise tolerance of the patient. Now, it's a blood test to check the alpha-1 antitrypsin deficiency, a genetic cause that can lead to COPD. Physician may order X-ray. X-ray may show emphysema, and sometimes they may also order a CT scan of the chest. Now, let's see the treatment of COPD. In COPD, bronchodilators are used. They are used via inhalation. What is bronchodilators? This dilate the smooth muscles of the bronchi and helps to relax the constricted bronchi. The bronchodilators can be short-acting and long-acting. What is short-acting bronchodilators? That means it acts quickly and gives immediate relief. It is used in emergency condition when a patient needs relief. Example, albuterol and atrovent. What is long-acting bronchodilators? The long-acting effects last longer and it controls the exacerbation. Example, Spiriva. So along with the bronchodilators, there are other inhaled medication called corticosteroids. They are given through inhalation because of its anti-inflammatory properties and prevent exacerbation. Example, Flovent, Pulmicort. There are combination inhalers. That means combination of bronchodilators and corticosteroid both. Example of combination inhalers are Advair, Symbicort, Breo, Trilogy, etc. So what are the other treatments of COPD? You saw the inhaled medicines. Along with that, physician may order oral medications. The oral medication ordered are steroids, again for the anti-inflammatory properties. Next is methylxanthine, example theophylline. It is bronchodilators given orally. When the patient is on theophylline, it is important to check the therapeutic level. The therapeutic level should be between 10 to 20. Also remember, theophylline increases the risk of digoxin toxicity and decreases the effect of lithium and dilantin. And the other oral medication include is phosphodiesterase inhibitors. It is given because of its anti-inflammatory properties. Other management of COPD include, if the patient is a smoker, encourage quit smoking. Get recommended vaccine, example flu shot annually and pneumococcal or pneumovax every 5 years. Use prescribed inhaler, medication, follow up with the pulmonologist. Also include oxygen therapy. Oxygen is delivered to keep oxygen, SpO2, in this patient between 88 to 92%. Why a low rate of 88 to 92? Usually in COPD, we give oxygen in a low rate, 1 to 2 or 1 to 3 liters. The reason is this patient has a hypoxic drive. That is, these patients are used to low oxygen in the blood, and this low oxygen stimulates the patients to breathe. So if you give high oxygen to keep SpO2 of 100, it is going to reduce their need to breathe. So they hypoventilate and carbon dioxide may increase. So delivering oxygen in a low rate, 1 to 3 liters to keep SpO2 between 88 to 92%. Also, adequate nutrition. Patient with COPD may not tolerate large or heavy 3 meals per day. The reason is large meals pushes the abdomen, pushes the diaphragm and compress the lung. So for COPD patient, encourage small, frequent, high protein meals. And finally, teach the COPD patient the breathing exercise. There are 2 breathing exercises that help this patient. One is pursed lip breathing. Second is diaphragmatic breathing. What is pursed lip breathing? Tell the patient to inhale slowly through the nose and exhale through pursed lip like blowing out a candle. How does it help? It slows down and reduces the work of breathing. It keeps the airway open for a longer time so the lungs can get rid of more trapped air. What is diaphragmatic breathing? In diaphragmatic breathing, tell the patient to relax comfortably, either sit down or lay down. Place one hand over chest and other over abdomen. Tell the patient to breathe in, and when the patient breathes in, the hands on the abdomen should rise, and tell the patient to exhale through pursed lip. And when the patient exhales, the hands on the abdomen should go down. This is diaphragmatic breathing. It helps to strengthen the diaphragm and decreases the work of breathing.